Good evening, dear colleagues, dear doctors, dear students from intensive care and other specialties. So today is webinar number 132 in the series of critical care webinars. And this is a very special webinar today. It's an honor and pleasure to welcome Dr. Subramanian Swaminatham, sir. Sir has been a great contributor to our webinars, and his last webinar, it's been a year now, has been very popular, and it continues to draw more and more viewers on our YouTube channel. Thank you, sir. That was a very popular webinar. Sir, just a brief introduction, though he needs no introduction, is a very regular contributor to teaching in India. It not only teaches infectious disease to ID people, but also other disciplines, especially all of us also who need so much of ID. Sepsis being the greatest mortality in the ICUs. So, sir, briefly, is one of the leading physicians from infectious disease in our country, and he's the director of infectious disease and infection control at Gleneagles Global Hospital, Chennai. Sir is chairman HIC, BGS, and GGH Bengaluru. He's chair infection control advisory group GGH Chennai, Bengaluru, Hyderabad. Sir is a program director of microbial medicine and infection control GGS Chennai, and he is a chair transplant ID subcommittee CIDS. In one word, sir is one of the greatest physicians from ID we have, just to simply put it.
So you're embarrassing me. You're embarrassing me. I'm going to stop you right here.
This is the least I can say, sir. This is the least I can say for you. No. Thank you, sir. Please, the screen is yours.
Thank you. Thank you. It's very nice of you to invite me. Thank you for having me here. So over the course of the next maybe 35 to 40 minutes, I'd like to talk about certain things with regards to infection in the setting of the ICU, because we can talk about antimicrobial therapy in various settings, but obviously I want this to be relevant to the people who are going to be part of this continuing effort that Dr. Bansal has been doing for quite some time. So let me first congratulate him on all the hard work that's been put into this. And I think it's lovely to have good education efforts like this. Okay. So my disclosures, I'm a very conflicted guy. I work with a lot of people. Let's start with some simple stuff. So let us say 65-year-old male. He has a neurotrauma, some accident, something. Now he has a CSF leak, right? He presents with fevers, chills, and altered sensory. Clinical diagnosis, obviously, you're concerned about a meningitis. So a spinal tap is done, shows about 1,000 cells, 99% neutrophils, and a sugar of 12 milligram per cell. Gram stain shows gram-positive cocci in pairs. So I don't think anybody is going to get any prizes for diagnosing what the patient has. It's obviously pyogenic meningitis. But the question would be, should we start him on a bactericidal antibiotic? Should we start him on a bacteriostatic antibiotic? Should we start him on one of each of these? It really doesn't matter what we give him. Or should we call infectious diseases? Well, for those of you who are not very sure, the answer is always E, call infectious diseases. But let's dig a little deeper to try and understand whether there's really any issue with regards to bacteriostatic and bactericidal. This is something that people keep talking about when we talk about sick patients. This drug is bacteriostatic, this one is cidal, therefore it's better. Nice, right? It sounds good, bactericidal. It sounds like you're really killing the bacteria. Therefore, it should be better. But are we really sure of this? It's good to have some amount of curiosity. Not too much because it killed the cat, but some amount of curiosity is good because we want to find out what is happening, but not at the cost of our own career. This whole concept of cidal and static, where did it come from? Well, the concept is probably, now it's about 45 years old. Okay, I was wrong in this. So it's nearly about 45 years old. And this was actually put up in I think it was a German journal. A guy of Indian origin from the looks of it, who actually brought up this concept of whether a static and a cidal could be an issue. Maybe other people have discussed it in the past, but he was the one who coined this term of static and cidal. So what is static? What is cidal? So we have certain biochemical parameters. We do some parameters in the lab to try and make out these things. One is called the minimum inhibitory concentration, the MIC. Everybody is aware of this because your microbial culture reports, when you look at it, it will say the MIC to meropenem is this much. The MIC to amikacin is this much, vancomycin to vancomycin is this much. And in some antibiotics, which we usually don't put up in the report, we have something called MBC. MBC is basically the concentration that is required to kill the bacteria by itself. MIC is the concentration at which you stun the bacteria so that it doesn't reproduce, but it cannot, you are not killing it either. So basically, you stop the bacteria from multiplying so that the WBC can go there, start engulfing and killing it. So the host has to play a role. But in MBC, the antibiotic by itself is directly killing the organism. So obviously, the antibiotic is doing all the hard work, not just stunning the organism. So there are certain, breakpoints that we have. We call it static if the MBC to MIC ratio is at least 16 or more, as cidal if it is 4 or less. So basically, if the MBC is close to the MIC, it is cidal. If the MBC and the MIC are farther apart, it is called static. And of course, there are certain time kill curves also we have for this. Don't go into too much of that. But understand that it is basically whether you are actually killing the bacteria or just stunning the bacteria. That's the basic concept between static and cidal. So far, it sounds good. So in theory, you would think if a bacteria is directly killed by the antibiotic, isn't that better? My boss used to tell me the meaning of the word assume is it makes an ass of you and me. Never assume. No. Right? So while it sounds like cidal is probably better than static, are we really sure? I think we need to look at the data. The first question is, do you know what kind of a drug your antibiotic is? So if you have, let's say, azithromycin or doxycycline or nitrofurantoin, do you know whether it's static or cidal? Some things are easy. Beta-lactams are generally cidal. Aminoglycosides are generally cidal, but not always. The traditionally bacteriostatic drugs are your protein synthesis active drugs like macrolides, tetracyclines, lysyl cyclines, sulfonamides, clindamycin, linezolid. These are all bacteriostatic drugs. The cidal drugs are all things which work on the cell wall, like beta-lactams, or they work on deep cellular machinery like fluoroquinolones, daptomycin, metronidazole, aminoglycosides, things like these are all bactericidal. So obviously, the cidal and static have different targets within the bacteria. This is the easy way to remember it. But unfortunately, life is never this simple. So it's also fun to note that some antibiotics are both cidal and static in different situations. What do I mean by that? So if you look at macrolides, they are actually bactericidal versus streptococci. So macrolides like azithromycin actually work very well against pneumococcus and streptococcus. So I often have wondered why we give ceftriaxone with azithromycin. Azithromycin by itself will work very well for streptococci. Of course, if the streptococcus resistance to azithromycin is rising like it is in some countries, it's a problem. But otherwise, azithromycin is actually bactericidal. Linezolid is actually bactericidal against streptococci like pneumococcus. While it's static against Staph aureus, it's cidal against streptococci. And quinapristine, dalfopristin, again, bacteriostatic against Ephesium. So again, the same antibiotic is different with regards to different pathogens. You would think that bactericidal therapy is lovely therapy. Sounds good. But can there be a downside to bactericidal therapy? What is wrong in killing bacteria very quickly and restoring the balance in favor of the patient? Well, not always. Sometimes it can be dangerous. I'll give you a hint. Think about tubercular meningitis. Why do we give steroids when we treat TB meningitis? Because the damage to the bacteria increases the cellular response from the host, and that causes a lot of collateral damage. It increases the amount of fibrosis and it can kill the patient. So remember that sometimes bactericidal therapy can result in untoward damages to the host, which you did not plan for a priori. So when you have bactericidal agents, this rapid lysis can release certain toxins inside the bacterium, and that can cause a lot of problems. For example, when we see gram-negative infections in children, we do not give them antibiotics before we give them steroids because they have a much higher risk of severe problems, including ototoxicity. Infant botulism. The problem is Clostridium botulism. The bacterium, if you give a bactericidal agent, you rupture the organism and you spill out a lot more toxins than the patient already had. Another example is enterohemorrhagic E. coli. Increase in cerebral edema. Pneumococcal meningitis is the poster child for that. Studies have clearly shown that if you give steroids before you give antibiotics, it really reduces complications due to pneumococcal meningitis. Here, it's not the pneumococcal meningitis which is causing the problem. It's actually the rapid cellular lysis which causes a lot of damage. So, and of course, in syphilis, this is probably the best studied. It's called the Yarish-Herxheimer reaction, where when you rupture the syphilis organism, there's a lot of these bacterial products which get out into the bloodstream, and then you have a skin reaction secondary to that. So again, all of these things are rapid rupture of the organisms in extremely difficult situations, which can be very, very hazardous to the patient, and therefore should be done with great caution. I'll give you another example. If you're dealing with wound tetanus, you obviously give the anti-tetanus immunoglobulin before you give antibiotics, because when you give a bactericidal drug, you're going to release more tetanus toxin into the patient, and that can actually make it worse. So understand that rapid bactericidal therapy may not always be in the best interest of the patient. And that's where sometimes, you would think bacteriostatic therapy may actually be good. So what happens is bacteriostatic drugs actually prevent the production of these toxins, and they may actually contribute to better outcomes. Example of clindamycin. So when you have toxic shock syndrome and drugs like and situations like that, where the toxicity is mediated by toxin formation, and there's a lot of toxins being pumped out from the organism, having an agent which causes disruption of protein synthesis is actually good for you. So clindamycin inhibits the TSST1 toxin by Staph aureus, irrespective of where it is in the growth phase. And that, what it does is it prevents more toxin dumping into the system, and therefore minimizes the amount of damage to the host. And it's more effective than penicillin in at least mouse models of myositis. So there again, here we have a situation where a static therapy is actually preferable to a cidal therapy. And static drugs generally have a longer post-antibiotic effect. And here's the problem. Except with some exceptions like aminoglycoside, a lot of the drugs, the classical example being beta-lactams, the minute the drug level goes below the MIC, the antibiotic does not kill any further. Meaning the bacteria will start multiplying as soon as the drug goes below the MIC. Of course, aminoglycosides, you have a post-antibiotic effect, but with beta-lactams, you don't. And remember, we use a heck of a lot more beta-lactams than we do aminoglycosides. So if the drug level goes down below the MIC, the bacteria starts multiplying. But with static drugs, you have a significant post-antibiotic effect. So there is suppression of the bacteria from replication even beyond the half-life of the drug. And this effectively correlates with the 24-hour AUC by MIC. So there are some advantages of bacteriostatic drugs. So what are the situations where we usually say, oh, we need to give a bactericidal drug? The best situations that we keep talking about are endocarditis, osteomyelitis, meningitis, and neutropenic fever. So we don't really care so much about skin and soft tissue infection or intra-abdominal infection and things like that. But these are places where we generally talk about static and cidal. And the first most common thing where this has been, this boogeyman has been discussed is actually with endocarditis. And I think it's always good to look back at the history, because that teaches us a lot. A lot of these mistakes have been made and we have learned from that. Rather, I would say we have made the mistakes again and again and we have refused to learn from that. So I think that's more accurate. So endocarditis is a uniformly fatal disease if untreated. So if you don't treat endocarditis, the chance of success was 0%. And prior to the advent of penicillin, there was uniform fatality, even though sulfa drugs were available. Trimethoprim was not available. Sulfa was available. And in spite of sulfa being available for streptococcus, it does work for streptococcus, the patients continue to die. So we knew sulfa alone is not effective. Cotrimoxazole is different. When you have two sequential acting static drugs, it becomes cidal. So when you have sulfamethoxazole followed by trimethoprim, the combination becomes cidal. Each one individually is static. We didn't have trimethoprim at that time. So sulfa alone, there was no benefit and people were dying. And what they showed was what could not have happened earlier now happened. With good doses of penicillin, endocarditis was being treated and cured, which was amazing, which was unheard of before. And the problem was for enterococcal endocarditis, penicillin didn't seem to make a difference. They were still dying. And this is where adding aminoglycoside changed the dynamic. So for streptococcal endocarditis, the arrival of penicillin really changed outcomes. And for enterococcus, arrival of aminoglycosides as an adjunct to penicillin changed outcomes. And all of this correlated with the bactericidal agents activity. And this is probably where this whole boogeyman of cidal and static started coming up. But let's look at it a little further. This is probably one of the earliest studies with antimicrobial agents in the setting of endocarditis. And this is from Dowling back from 1952. This is the original graph which I've taken from his publication. And as you can see it, they looked at different kinds of treatment options they have looked at. They looked at patients, this black dots over here is patients who had no treatment. Obviously, all of them died. Specific anti-sera, that was very popular. Many of us, we talk about monoclonal antibodies and we get excited. This concept of using immune-based options like pneumococcal anti-sera is very, very old, more than 100 years old. Before antibiotics came, that's what we used. Still doesn't work for this. Sulfonamides, there is some benefit. As you can see, the graph is not as bad as untreated. But proper antibiotics like penicillin obviously is much, much better. So clearly, there was a significant benefit with the use of penicillin-based antibiotics as compared to even sulfa or no treatment. And sulfa was still effective. So bacterial endocarditis, what we need to understand is that there is a very high density of non-replicating bacteria. See, inside every vegetation, the inoculum load is astronomically high. Many of them are in a situation of suspended animation where they're just sitting still and they're not necessarily replicating. And you can only kill the replicating bacteria when you give antibiotics. What about staphylococcal endocarditis? Clindamycin in one early study showed a 70% cure rate. And this was similar to what they noticed with beta-lactam with or without antibiotics. But the relapse rates were higher. And this is probably because in those days, we did not know about the inducible resistance with clindamycin. And we thought that if clindamycin susceptible came up, then you can use it. We now know that saying susceptible does not mean it's susceptible. You have to look for inducible resistance. So going further in bacterial endocarditis, what about cotrimoxazole? Cotrimoxazole was effective. In 43 patients in one study, 37 were cured, and the toxicity was comparable to vancomycin. The failures happened only in MSSA. So for MRSA, it was actually very, very good. And we know for MSSA, not using a penicillin actually is bad because using something like flucloxacillin or cefazolid has a survival advantage over compared to any other drug for MSSA. And of course, here combining with daptomycin could be an option. So, can we use static drugs in endocarditis? Sorry. What about vancomycin-resistant endocarditis? Oral linezolid has been used. Linezolid is the poster child for static in this setting. Of course, it's anecdotal. Nobody is going to do a trial in this. But there's lots and lots of cases now published where they have successfully used linezolid in VRE endocarditis. I do not recommend using linezolid as a upfront therapy, but it could be one option in salvage therapy. But today we have daptomycin and we even have dalbavancin which has come out. Again, we need to look at the pros and cons of which one we can use. But linezolid certainly is one option. So this was a publication back from 2005. So 20 years ago itself, you can see the number of patients who had got linezolid and they had very good outcomes. As you can see, the majority of patients have been cured with the use of linezolid in treatment of VRE endocarditis. So again, so this is an example of a static drug which did very, very well. So what about other drugs in bacterial meningitis? The terramycin was used in early studies and it was shown to be very effective. What about chloramphenicol? Chloramphenicol is variably effective and we do not use it for penicillin-resistant pneumococcus because cross-resistance to chloro is very high. Linezolid has also been used in VRE meningitis. I've also used for penicillin-resistant pneumococcus, where there is high-level resistance to cephalosporins and meropenem. I found linezolid to be excellently effective. Cotrimoxazole has also been used for bacterial meningitis and ventriculoperitoneal shunt infections. I have used it for quite a few nosocomial shunt infections and things like that, where you have certain difficult to treat infections like Elizabeth Kingia, Trisobacterium, and things like that. Excellently effective. So obviously, and chloramphenicol used for meningitis is not that unusual. Many of you are fairly young and you're unlikely to know this. I remember during my medical student days, I used to see patients who came into the ward with a diagnosis of pyogenic meningitis. And in the standard treatment protocol for those patients used to be benzyl penicillin with chloramphenicol, because benzyl penicillin was excellent for pneumococcus. Even today, we don't, even today, benzyl penicillin is excellent for lung infections with pneumococcus, not for CNS. But in those days, we didn't have pneumococcus, which is penicillin resistant. We used to use benzyl penicillin with chloramphenicol. It was excellently effective. What were we using chloramphenicol for? Primarily for Haemophilus influenzae. That was very, very effective. So again, can it be bad in the setting of meningitis? Yes. What they showed was in rabbit models, when you give cefotaxime or any beta-lactam for that matter, there was increased endotoxin production and that caused death. And on the other hand, when you use a static drug like chloramphenicol, you did not see this endotoxin production and dangerous issues like brain edema. And remember, the large study which was done with regards to pneumococcal meningitis, even in adults, showed that giving them steroids before he gave them the antibiotics actually is very, very protective. Problem is that the cidal agent causes so much collateral damage. So when cefotaxime was introduced, there was a lot of endotoxin production. And with chloramphenicol, there was less lipopolysaccharide being dumped out. And they were even suggested that maybe we should think about adding rifampicin to it. But all of that has fallen to the wayside now that we've got the standard use of steroids in the treatment of pyogenic meningitis. What about chloramphenicol? I still love this drug. It is as good as penicillin, ceftriaxone, or ampicillin in meningococcal meningitis. It was as good as ampicillin in many trials. Adding penicillin did not change the outcomes. Remember that somehow we have this feeling that maybe we should use multiple antibiotics, does not make it better. Drug resistance obviously is bad, and that is true for any drug. So if you have chloramphenicol resistance, why would you use chloramphenicol in the first place? So the case of chloramphenicol is probably the best. Remember, this tells you that chloramphenicol did as well as all the comparator antibiotics in the treatment of meningitis, and therefore this boogeyman saying static and cidal doesn't make sense. And one could even argue that when you use chloramphenicol, you don't need steroids as well. So chloramphenicol has been the first line antibiotic in treatment of pyogenic meningitis for many, many years, but it's again static. But again, like I said, chloro is cidal against H flu and strep pneumonia, and it's static against others. So treatment of meningitis wise, Leper and Dowling study was probably a landmark. When they looked at pneumococcal meningitis, mortality with penicillin was 21%. When they used a static agent with that, aureomycin, it was 79%. So as you can see, there was a significantly higher mortality when you combine a static and a cidal. And this is something that we often talk about. Don't add a static and a cidal because the static will prevent the cidal from working. Remember, cidal drugs only work when the bacteria are multiplying. Static drugs stop the bacteria from multiplying, and therefore the cidal drug is just standing around wondering what to do. So the Matthew study, again, children with meningitis, ampicillin alone, mortality is 4.3%. But when you add multiple drugs, including a static drug, you see that the mortality was higher. So again, more risk of death and more risk of complications when you add static drugs as well. So when you look at put all these data together, there's clearly a higher risk of death when you combine a static and cidal drug. So do not combine these two, especially in the setting of meningitis. Choose one. What about osteomyelitis? Bone concentrations have always been very, very poor, but certain drugs get very well into the bone. Clindamycin is a lovely drug. Tetracyclines are also excellent. And we have very good data for clindamycin for gram-positive osteomyelitis. I am very comfortable using clindamycin as treatment for osteomyelitis for my outpatients, not inpatients. And of course, can be used as adjuncts. Nothing wrong with using clindamycin if you have MRSA, diabetic foot infection with only MRSA. So obviously, even in osteomyelitis, there is very good data to suggest that you can use it. So both in endocarditis and in meningitis, there is data to suggest that in selected patients, you can use a static agent, and there's really no concern. And again, even in osteomyelitis, the static and cidal doesn't make sense. Neutropenic fever is the only place where we have not studied static agents all that very well. It's because we believe that the host immune system is so poor and the neutrophils don't really work that we have to rely on the drug itself to kill the bacteria. But then remember, when the MICs are so high, the MBCs are going to be even higher. You're not going to get to those kind of levels in the patient without killing the patient with side effects. And therefore, I would argue that many of the antibiotics that we're using in patients who are sick are actually being used with static intent, not the cidal intent. But there is some data about using static agents like linezolid, and there was benefit in patients with neutropenia. When we looked at randomized trial against vancomycin, linezolid had comparable mortality. It was or comparable efficacy, whichever way you put it. So again, it's not like there is no data. The data is reasonably small. So what we can say is the in vitro definition may not correlate with in vivo activity. What you think of as uh, static and cidal in vitro may not be the same in vivo. And the clinical distinction between static and cidal is actually situational. You have to look at the site of the infection. You need to know the inoculum load. You need to know the PKPD characteristics of the antibiotics. And you also need to keep in mind the host defense mechanisms. I mean, too much is too bad, too little is too bad. So, neutropenic fever, it is too little. In meningitis in a good host, when you have a lot of cell lysis, that's too bad because it actually correlates to higher poor outcomes, and you have to chase it with steroids to keep it down. So, for many infections, there is no data to say that bactericidal therapy is superior to bacteriostatic therapy. So, in summary, what I would say is in the ICU, when you're making a decision on using an antibiotic, please do not consider static and cidal as a concern for choosing antibiotics because in practical situations, it really makes no sense at all. So I hope I have shown you enough data to say that in most situations, it is more our own mindset rather than a clinical problem. So in clinical situations, look at the susceptibility of the organism by looking at your own hospital antibiogram, penetration, look at the antimicrobial agent, how quickly you can inhibit the replication, all those things, and whether it's a toxin mediated injury and things like that. All of those things are important. Let's look at another situation. I have a 47-year-old lady who undergoes a liver transplant. Post-operatively, her pressure requirement stays high, and the FiO2 need is slowly reducing by day 2. The ICU team notes that there is significant secretions in the endotracheal tube, and there is concern for sepsis from a pulmonary source. You can substitute this liver transplant for any patient. Let us say this patient came in with trauma or anything. So we are worried about here is that whether this could be a pulmonary infection or a pneumonia, and whether we can use biomarkers here, specifically procalcitonin. So the question is, will the procalcitonin help me identify a pneumonia? Will serial values help me predict outcomes? Will it help reduce antibiotic use? Or is it that procalcitonin is really unproven at this point? A lot of us use procalcitonin. I'd love to have seen all of you to ask you how many of you use procalcitonin in day-to-day practice. But I very honestly suspect that procalcitonin use is something that is fairly common. Dr. Bansal, how common would you say is procalcitonin use in most ICUs in India?
Sir, it was rampant till the last guidelines came up. Now it is dying off. People have become
It's dying off.
aware, but still it is being used there.
Right. So I think the problem is the pendulum swings from one extreme to another extreme. Either we say, oh my God, this is the holy grail, everybody has to do procal for every patient, we need it every day and all that. Or we then move 180 degrees and then say it is totally useless, throw it away. So the question is sometimes, are we throwing out the baby with the bathwater? So use of procalcitonin in my mind is almost an art as much as it's a science. But about nearly a decade ago itself, AHRQ had warned about this. AHRQ is the Agency for Healthcare Research. It's a non-profit, government-funded organization in the US, which gives out excellent advice, and it's something that I keep visiting once in a while at least to see what's new. So, is there a need for using biomarkers to guide antibiotic therapy? We know certain things. Early and appropriate use of antibiotics is important in managing critically ill patients with suspected bacterial infections like sepsis. Check. Patients with upper and lower respiratory infections, especially the ambulatory or hospital care settings. Okay, check. Pediatric patients, check. Post-operative patients, check. All of this we know. But the question is, how do you identify this? The problem is, it is very difficult to differentiate between infection and infection-like mimics. This could have been, say, fluid overload. This could have been a drug reaction. It could have been pulmonary embolism. It could have been so many different things, including a tracheobronchitis and not a pneumonia. And the current recommendation says, don't treat tracheobronchitis. So how do we know that it's an infection? And the problem is currently, because of the concern of infection, rightly so, there is a heavy overuse and misuse of antibiotics. And this does lead up to cost, side effects, and of course, the problem of antibiotic resistance. So, how do you find a middle ground where we say this patient needs antibiotics, this patient we can wait and watch? And like all great things in life, nothing is easy. So, problem is also that once you start an antibiotic, there is also a lot of inertia in being able to stop it. And we are very uncomfortable about saying, I think we've given enough, let us stop and take stock of it. So, what about procalcitonin? A lot of biomarkers have looked at it, both for local and systemic infection. At last count, more than 170 biomarkers have been evaluated. And honestly, some are better than the others, but nothing is perfect. Procal is probably the most extensively studied biomarker among all these. Of course, we know what it is. And it is to identify local or systemic bacterial infection, is what the idea is. And of course, it has to be combined with algorithms. This is what the original premise was. What are the cutoffs? Healthy people, generally procalcitonin is much less than 0.05. But again, each person is different. So therefore, we don't know what your baseline is or what my baseline is. What is more important is a rise from baseline rather than a single number. So most people would use either a cutoff of 0.5 or a 0.25. The higher it is, obviously, the more likely it is. And again, we are talking about likelihoods. We are not talking about diagnosis. It's like saying a beta D glucan for candidemia. Higher the levels, greater the probability. It's a rule out test. And that's the problem. When we take it as 0.25, it either means no infection or resolution. In neonates, we have to use normograms. And the problem in post-operative patients like this is that surgery itself will raise it. And therefore, unless we have serial measurements, we won't know where it's going. Because there's a lot of cytokine release due to trauma or surgery or whatever it is, or burns for that matter. And therefore, we can't look at a single number and make any decision. So how can we use it in critical care? In some studies, it has reduced antibiotic use. And I will tell you very honestly, in my hospital, we have now reduced the use of Procal, but Procal was very key in being able to reduce the duration of antibiotics. The problem is when you have a patient who has an infection, by day 5, let us say the patient has a pneumonia. By day 5, the fever may not have gone away. The white counts may still be on the higher side. How do you get the courage to stop antibiotics? And this is where Procal helped. We were able to show 80% fall in Procal, and that helped me convince the intensive care guys. I have a fantastic team, fortunately, that it was okay to stop therapy. Now, today, because of the confidence that they've gained from that, they've given up on the Procal and they're able to very comfortably, based on clinical decision making itself, say, I'm not worried about the small spikes of fever. I'm not worried about the white counts. It's okay to stop therapy. But I honestly believe procalcitonin gave us the confidence to do that in reducing antibiotic use to 5 days duration. And does not change mortality, of course. Again, this can be discussed. If you look at Evelyn de Jong's paper, long-term outcomes with the use of procalcitonin guided reduction in antibiotic use is actually useful. Overall, I think the point is the more you use antibiotics, the worse it is for the patient. The problem, the biggest concern, of course, is intensification. If the procalcitonin doesn't go down and it goes up, and it can go up for 101 different reasons, patients invariably get more drugs, and that is not necessarily helpful. A fall in Procal is useful, a rise in Procal does not mean anything. And therefore, it's important for us to remember there are 101 reasons why a Procal can go up, which has got nothing to do with the infection and should not be an indication to give more drugs. And when you do that, when you do unnecessary Procal monitoring and end up giving more drugs, the patient ends up being longer in a hospital, longer in the ICU, longer on ventilator, and have more risk of renal dysfunction and all kinds of problems. So it all around, and of course, obviously higher costs. So be very careful about Procal rises because you don't know what to do. So obviously, we don't know if it can be used in post-operative patients. In minor surgeries, it probably doesn't do anything. And serial recommendations, so serial numbers are what was being recommended. If you are in the process of using Procal, use it wisely. Otherwise, if you're comfortable doing what you need to do without doing procalcitonin, that's also okay. And I don't think that's necessarily the worst crime under the sun. The last point I want to discuss, okay, we are coming up to nearly 45 minutes and I want to stop at 45 so that we can have some discussions. Understanding antibiograms. You know, when you're in the ICU, a lot of you may have access to a hospital antibiogram. Dr. Bansal, would you say it's common practice for most ICUs to have a antibiogram being given to them by the hospital infection control and microbiology team?
Sir, I don't think so, but there are meetings where antibiograms are discussed, monthly meetings.
Discussed. Okay, so let's talk about this because this is something that the NABH is also becoming more and more anal about, having a hospital antibiogram and an antibiotic policy based on that. For a lot of people, it is very confusing, and I'm going to talk about it for a few minutes. I'm having two patients here. The first one is a 25-year-old lady who presents with fever, flank pain, and burning micturition for 1 week duration. She's got fevers and chills and rigors. She's got flank pain. She's when she's peeing, she's she's literally jumping up and down because it hurts. What is her diagnosis? It's pyelonephritis. I'm sorry, no points for that. You do you admit her to the ICU because she's got some tachycardia and counts are high. She just generally looks not so great. You're pushing some fluids in. You get a blood culture. You get a urine sent immediately from there. Urine shows a gram-negative bacillus, and your primary pathogens in your hospital are E. coli and Klebsiella from the urinary tract. You know, worldwide, your top pathogens are E. coli and Klebsiella from the urinary tract. So that's what you need to cover. But how do you cover this? Let's take a second patient. On the other hand, in your ICU, there's a 37-year-old RTA victim who's been in the ICU for the last 2 weeks. This guy has had multiple fractures, rib fractures, and all that, and he's been on a vent. We understand that. Awesome. On the vent, he now develops a new onset of fevers, increased purulent sputum or secretions rather, raised FiO2 need, and there's a new patch. No points for diagnosing what this is, and no points for diagnosing what my cough is. But this guy has a pneumonia. Well, we can call it a ventilator associated pneumonia, whatever it is. That's fine. Let's just say pneumonia. What do? You want to start antibiotics, you send off a sputum gram stain. It shows gram-negative bacilli. And in your hospital, in your unit, you don't have acetato, and your top pathogens are either Klebsiella and E. coli. Let us say it is that. So again, you have two situations here. And both these situations, you're worried about E. coli and Klebsiella. Just keep these two situations in mind. And let's look at what the hospital antibiogram is. I've just made up a very generic hospital antibiogram. Most hospitals are going to look very, very similar. E. coli and Klebsiella today, susceptibility to penicillins and cephalosporins is very bad. The ESBL rates, even in the community, is about 70%. So, would you trust ceftriaxone for any of these patients? The answer is no. When was the last time you started a pyelonephritis and said, "I'm going to give ceftriaxone"? No, you're not going to give. Would you give ciprofloxacin? Again, look at that 20%, 15%. This is susceptibility. Pretty bad. Nah. Piperacillin tazobactam. Oh, piperacillin tazobactam for E. coli sounds good, 70%. Ertapenem, E. coli, 85%. But Kleb pneumonia, 45%. This looks good. This looks bad. Okay. Now let's look at this. Let us say, for the sake of discussion, both of these patients grew E. coli. The young lady grew E. coli in her urine culture and her blood culture. And the young man, who's the RTA victim, grew E. coli in his blood culture and the ET culture. What antibiotic would we give? If I give you an antibiogram like this, you would think 85% of your E. coli is susceptible to ertapenem. That sounds good. So why don't we give them meropenem? The answer is that's where antibiograms have to be interpreted with caution. Most hospital antibiograms are done like this, and to me, it makes no sense. This patient, the young lady, is a patient who comes from the community where your risk of carbapenem resistance is close to 0%. Drug resistance is like pregnancy. You're either resistant or you're susceptible. You cannot be partly resistant. It's like a woman saying, I'm 50% pregnant. You cannot be 50% pregnant. Either pregnant or you're not pregnant. Or if you're worried about ICU, your patient is either alive or he's dead. Can't be both ways. So the problem is this E. coli, the probability of this being carbapenem resistant is probably close to 0%, meaning carbapenem susceptibility is close to 100%. So this young lady, if you use carbapenems, you're going to be fine. Meropenem is going to be great. But for this patient, your meropenem resistance is very, very high. So using meropenem in this patient would be a disaster. Why is it like this? The problem is the majority of E. coli comes from the community infections, which is meropenem susceptible. And the majority of your Kleb comes from your hospital infections, which is meropenem resistant. So let us say You had 100 women who came from the community, which were all ertapenem susceptible, and you have 15 patients in the ICU, which were all ertapenem resistant. That will give you an 85% ertapenem susceptibility. But they are two different populations. The same thing with Klebsiella. If you have Klebsiella from the community, it's very likely it's going to be ertapenem susceptible. If you have Klebsiella from the ICU, they're going to be ertapenem resistant. So 45% of your Klebsiella come from the community, which is ertapenem susceptible, and 55% could be from the ICU, which is ertapenem resistant. So therefore, this doesn't make any sense. You need to understand the setting, and some hospitals have made it very user friendly, because using this antibiogram does not make any sense. So some hospitals have broken down this into antibiogram based on where you are. Admission antibiogram. So cultures taken within 48 hours of the patient being admitted. What is the susceptibility? That is useful because the patient comes into the community. You look at that antibiogram and say, uh, ertapenem susceptibility 99%. Okay, carbapenems are fine. Patient in the hospital for a week or more and then develops an infection. And you look at it and say, ertapenem susceptibility 10%? No, I can't use ertapenem here. If we can have microbiology to give you a split like that, that would make more sense. Unfortunately, because it's a lot of work and there is no way administration is going to support that with increased funding, we now have antibiograms which really don't make any sense. And as an experiment, when I joined Global 11 and a half years ago, for over the next 6 months, I actually sat down and manually did it. And I was able to show the difference between these two. And it made stark contrast. I was still looking for the data set. I just couldn't find it in time. But therefore, so for clinicians who are looking at this, the antibiogram is a good starting point. But the antibiogram by itself does not tell you what to use. So if you had a patient who came in from the community, you can definitely go for a carbapenem. Let us say it is Klebsiella, you can go for a carbapenem. But if the patient is in the hospital, even if it is E. coli, you do not trust a carbapenem. You'd have to go for something else, maybe amikacin or colistin or tetracycline, whichever is appropriate. Whichever is appropriate. See, the cotrimoxazole, 85% sounds good. But again, the majority of this will be the community, not from the hospital. So again, unless you have the splits, you don't know what is what. So again, so if the patient is in this patient, the first patient, I would definitely use the carbapenem because that would probably make the most amount of sense. And for the second patient, I would treat it as a carbapenemase resistant organism while I'm waiting for the susceptibility to come back. And today's day and age, this patient should probably get ceftazidime with astrinam combination because that's proven to be superior to every other form of therapy. And for the first patient, any carbapenem, whether it's imipenem or meropenem, should be good. Not any carbapenem, not a type 1 carbapenem. A type 2 carbapenem like imipenem or meropenem would be appropriate. And then while we wait for the susceptibility, you can then look at the susceptibility of that particular organism and decide how to de-escalate. So it will be, for those of you who are really interested in understanding more about this, I would encourage you to try and look at the hospital antibiogram and in your own mind, do this exercise and see how does it fit in with my patient. Understand how it splits between community infections and nosocomial infections. Acinetobacter is easy. You do not have community-acquired Acinetobacter infections. So all of it will be nosocomial. But E. coli and Klebsiella definitely, because most of it is, it's a split between nosocomial and community, it's going to be mixed. And therefore, it is worthwhile for you to understand this and use the data appropriately. And I think with that, I'm going to stop. Let's see if you have questions.
Thank you, sir, for another wonderful session. Lots of learning, and I hope all the audience can also take this forward into their practice. So while we wait for some questions, sir, maybe I can just put up some things. The one is about static and cidal drugs, like you said, bacteriostatic and bactericidal. And you said there's no real difference, and one should really look at the sensitivity and things. But one concern is, sir, about the immunosuppressed patients. You yourself said there is no data. You said about febrile neutropenia. So is it okay in immunosuppressed patients also about static and cidal?
Okay. So the problem with immunosuppressed is that it's a very broad group of people. A diabetic is immunosuppressed. A person on steroids is immunosuppressed. A person with rheumatological disease is also immunosuppressed. person with cancer chemotherapy is immunosuppressed. So again, it also depends on the kind of immunosuppression. Remember, for most pyogenic infections, I'm not talking about TB, I'm not talking about histoplasmosis and things like that. We will deal with things like E. coli, Klebsiella, Staph aureus, things like that. For most of those, it's about your neutrophil function. That is the key thing, and that's why neutropenic fever is dealt with separately. If you are not having neutropenic fever and your neutrophils are fairly active and able, see, there are some people with neutrophil function defects, Chidiac, Higashi, whatnot. Those will also come in neutropenic fever. Except for those, every other person, whether it is people who had monoclonal antibodies, people who had bad diabetes, whatever it is, you control the underlying factor. The neutrophils are working well. The same rules apply. I would still not make a distinction. Yes, obviously, because of their underlying poor medical condition, they have a higher vulnerability to complications and a higher risk of death. But the static and sidle is not going to make a difference in terms of outcomes. So the static and sidle probably only in neutropenic fever, it probably is unclear at this point of time. Outside of that, practically in every other circumstance, I don't think we should make a distinction.
Right. So then coming to carbapenem, some carbapenems like doripenem. Patients often have a tendency to throw seizures, but I've seen they're still on meropenem. Now, one of the great advantages of doripenem is that it hardly has a seizure throwing potential. So, but people are not using doripenem even in these situations. So, is it that it does not cross the CNS or what, sir? Why doripenem is at the...
Okay, so doripenem has been under cloud mainly because of the dosing issues. For a long time, they could not figure out what the right dose of doripenem is because whether it is 500 Q8 or 1 gram Q8 or even higher. And there seemed to be a split depending on the location of infection. With imipenem and meropenem, it was fairly well defined and we knew exactly what the dose was depending on the kind of infection we were dealing with. With Dori, it was a bit of a problem. That makes it more difficult to use. See, most clinicians want an answer which is easy to use, broadly applicable, and does not involve too many mental gymnastics in trying to figure out how to use it. And that's where doripenem kind of fails. With imipenem and meropenem, if you have meropenem, it's 1 gram Q8H, and if you're talking about meningitis, it's 2 grams Q8H. With imipenem, it's 500 Q6, meningitis 1 gram Q8. That is easy to understand. But with Dori, the split is not that clear. That's one. The second thing is most labs do not give you Dori susceptibility. You have to infer it from IMI and Mero susceptibility. And a lot of clinicians are uncomfortable with it. This is also true for the new carbapenem that's come out, the biopenem, because a lot of people come and ask me why I'm not using biopenem. So when we don't know the breakpoints and we don't have enough clinical data, the question is how do we know? The third thing is that you cannot infer susceptibility from IMI and Mero. I'll give you an understanding of that as well. You can have, in certain bacteria, especially like Pseudomonas, you can have differential susceptibility among carbapenems. You can be IMI resistant and Mero susceptible. You can be Mero resistant and IMI susceptible. Because when we talk about drug resistance, we are only talking about enzymatic, CRE. But there are a lot of non-enzymatic drug resistance mechanisms as well. For example, efflux pumps, porin channel loss, and now we are having PPP mutations. PPP mutations is now more an E. coli problem as yet. We haven't seen it in Klebsiella. But coming back to the porin channel and efflux pump, these are issues. And for Pseudomonas, it's a big issue. So therefore, for Pseudomonas, you cannot predict susceptibility based on any of these rules. You just go by the susceptibility report. So if you don't have doripenem being tested, you don't know if it will work or not. So for a lot of reasons, some hospitals have stayed away from doripenem, and that includes me. I'm very uncomfortable. Same thing with biopenem as well. I've stayed away from it simply because it's a little difficult to extrapolate, and having to do mental gymnastics every time makes it a little more difficult. This is not to say that doripenem is an ineffective antibiotic or that is somehow substandard. No, it is just that it involves an extra step, and I believe in minimizing the workload for the practicing clinician simply because I believe in making it as user friendly as possible. That's all there is to it. It's not because of efficacy reasons.
Right. Thank you, sir. So then moving on to another thing about enterococca, you mentioned in endocarditis, where definitely it has to be treated. But literature mentions, sir, that in community-acquired intra-abdominal infections, you grow enterococca, you don't treat it. No, it doesn't make any difference. However,
Right.
in nosocomial infections, if you get enterococcus, you got to treat it. So wait, what happens here, sir? What is the difference?
So Enterococcus, remember, is not a very virulent pathogen. Streptococci are very virulent. Staph is virulent. Enterococcus are not at all virulent. They are very lazy bacteria, which are more like what shall I say? Opportunists. Yeah, that's the word for it. They are opportunists. They are not aggressive all by themselves. So the general rule of thumb for Enterococcus is, if it is part of a polymicrobial flora, you don't have to treat it. You treat it if it is a monomicrobial infection, or you find it in a blood culture or in the CNS or something like that. Outside of that, if you kill the other bacteria, Enterococcus will roll over and die because the milieu is no longer comfortable for it. So Enterococcus by itself is not virulent. And like if you have a nice vegetation in the non-bacterial thrombotic endocarditis and the Enterococcus is going past, it'll just go latch on and be comfortable over there. Staph, on the other hand, can invade a normal cardiac valve, destroy it, and cause endocarditis. That's the difference between Staphylococcus and Enterococcus. Enterococcus is a lazy bacteria which does not want to do any hard work, and that, in a way, helps us.
Right. So now just the last couple of questions looking into the future. So what antibiotics can we expect, sir, in the coming? A lot of antibiotics that come up outside, ceftazidime, etc., going to come up in our market?
Okay. So there are lots of anti-infective agents which are coming up. I'll expand that. Antifungals, there are quite a few antifungals on the anvil. Razafungin is a once weekly echinocandin, which is really exciting. There is ibraxafungar, which works very well for drug resistant candida. There is olorofim and fosmanogepix, which is being studied for non-mucor mold infections, including Fusarium mosquitospore, even things like that, which are very exciting. So fungal world, lots of lots of good things coming up. Viral world, obviously, there are two anti-CMV drugs which are coming up, which are very exciting. Uh, Antibiotics are the problem where we are facing. Gram-positive world, because the Western world is very worried about gram-positives. There's a lot of drugs coming out. Dalbavancin has now been launched in India, which is once weekly. Mighty convenient when we're treating skin and soft tissue infection. You give them a one dose, they can go home, come back after a week, get the second dose, and they're fully treated. Gram negatives, on the other hand, we have a severe problem. We are running out of drugs with regards to gram negative infections. Of course, there are some drugs in the pipeline. You talked about cefiderocol. The problem with cefiderocol is that I call it a Maha tigecycline. Uh, in that there is numerically more deaths in cefiderocol treated patients as compared to comparators. Just like how tigecycline had a black box warning saying there is numerically higher deaths in patients treated with tigecycline as compared to comparators. So cefiderocol is nice, but it's not a game changer. The game changers would be, one will be ceftaroline. Ceftaroline is an excellent drug for community-acquired respiratory tract infections. Why do I call it a game changer? In my hospital, I've been able to bring down meropenem use thanks to ceftaroline. Why? Because remember, the more we use vitamin M in the ICU, the more problems we have. We need to find alternatives for vitamin M. And I think ceftaroline is a good option where we can limit the use of vitamin M and use a different agent, which is more appropriate for respiratory tract infections to come to the community. That's one. The second one for extensively drug resistant gram negatives is cefepime-zidabactam, which is an Indian molecule by Wockhardt. I've had the opportunity to use it last November. I think I was the second person in India to use it. Somehow I end up using these drugs very early. I was the first person in India to use ceftazidime-avibactam back in 2016, 17, something like that, within a month of its release in the US. And I'm the second person to use cefepime-zidabactam in India. Lovely drug, very promising, has a lot of benefits. And there are lots of newer beta-lactamase inhibitors like nacubactam, taniborbactam, durlobactam, things coming out. But it's going to become more complicated because each of them have a vulnerability. Like this one has, it doesn't overlap perfectly. It's not like tazobactam and sulbactam. It's not a fixed one over one. You cannot use it alternatively. Certain things have certain advantages. Certain things have certain advantages. See, for example, in our country, we don't have vaborbactam. It's useless for us because it doesn't cover oxo-48. We don't have relibactam. Again, doesn't cover oxo-48. It's more for the KPC world. We use avibactam because although it covers KPC, it primarily covers oxo-48. We are waiting for the newer BLIs like I said, zidabactam. Zidabactam is undergoing phase 3 trials. I honestly believe it's going to be a great winner. And of course, the other ones like narcobactam and durlobactam and things like that.
Yeah, thank you, sir. So just last question, sir. Again about the future. The West has come up with a lot of data on therapeutic drug monitoring, and that becomes
Yes.
very important in renal failure and dialysis, because a lot of our patients in renal failure and dialysis, and in fact mortality in sepsis on dialysis is linked to inadequate drug concentrations. And now, with the AI coming up in such a big way, and AI and TDM being linked, you think we are going to be seeing the advent of TDM in India also, sir, for more drugs soon?
Thank you for bringing that up. There are two important points you made. I'll just reiterate for our audience. Number one, more patients die of sepsis and septic shock than they do of drug side effects. We should not be worried about dosing aggressively in the ICU, because the chance of the person dying of a drug side effect is astronomically low. The chance of the patient dying of the infection is astronomically high. So let's stop worrying about drug side effects. Let's dose the drugs as aggressively as we dare to. Invariably, what we do is we always step up the dose of antibiotic, and we see that it makes a difference. There's a difference between acute renal failure and chronic renal failure, and we cannot be using CRF guidelines for ARF. And therefore, my rule of thumb is I always go up to the next block. So when we have above CRCL above 80, 50 to 80, 20 to 50, and below 20 or whatever it is, I go up to the next one and use that one. And that generally is a little better than just doing this. I'm just saying that's my policy. I'm not saying that's the right way to do it. TDM is great, especially because you have hyperfiltration in setting of sepsis. But unfortunately, that's going to take more time for it to come out. But I think that's going to be useful. The last thing is about AI. I honestly believe artificial intelligence is no match for human stupidity, and therefore I am not worried about AI simply because some of the bad decisions that people make, and this is across the board, whether it is our patients or their families or whatever. Some of the bad decisions that are being made cannot be undone by AI. I think we need to fix some of the common sense things that we can do. And honestly, I believe that AI could be a boon, but I am going to stick my neck out and say, given that medical practice become more and more complicated and requires too much of analytical thinking, which AI is going to struggle with at this point of time, I still think that a physician is not going to be replaced by an AI engine very, very soon or in the near future. So I think we are all going to be safe, at least in the near future. But I still think there is going to be a real value in good old gumshoe work in terms of history taking and trying to understand what's happening with the patient. And that cannot be replicated by AI. And that's where I think our skill sets are going to be absolutely, absolutely safe. And we need to sharpen this on a daily basis.
Great, sir. So let us see, sir, where AI is going to go. Is a lot of things coming up with AI. Yeah.
Yep.
Thank you very much, sir, for
My
your
pleasure.
for the education, and it'll be up on our channel soon, sir. Thank you very much.
Take care. Bye.
Thank you.